Hello and welcome to the Vascular podcast from Radcliffe Vascular. My name's Andrew Choong and I'm an Associate Professor of Surgery at the National University of Singapore and a vascular and endovascular surgeon at the National University Heart Centre. I'm delighted to be joined today by three eminent vascular surgical colleagues of mine from Singapore, and we want to talk to you about critical limb threatening ischemia and giving you our perspectives from Singapore. Our panelists today include Associate Professor Tang, who's a senior consultant at the Sengkang General Hospital. Tjung, another UK graduate from Queen's College, Cambridge, who completed his higher surgical training on the University of Cambridge and Addenbrookes rotation, achieving a Doctorate of Medicine, looking into carotid plaque information. A previous British Society of Endovascular Therapy fellow, he's gone and undergone further endovascular training at Leicester and the Prince of Wales in Sydney. He has been in Singapore for approximately 6 years now and has a deep and active interest in lower limb research and is one of our clinical trialists here in Singapore. Last but not least, I'd also like to introduce Associate Professor Andrew Choong, who is also a vascular surgeon here at Singapore, but operating out of Sengkang General. He underwent his general and vascular surgical training in Oxford, and he is also one of a few UK trainees to receive the British Society of Endovascular Therapy Endovascular Fellowship. He has a PhD awarded by the St. George's Vascular Institute from the University of London and is an active researcher with over 100 publications in peer-reviewed journals, and he is also an active clinical trialist here in Singapore. So thank you very much all for joining us. Good evening to you all. It's 10 o'clock here in Singapore, and I hope it's at a slightly earlier time where you all are. You all bring very unique perspectives to vascular surgery and the treatment of peripheral arterial disease.
Eddie, could I ask you, how have you found the transition from a UK practice to a Singapore practice? And over the time that you've spent here, has your own practice changed? And what are the difficulties that you're finding specific to Singapore and Asians?
Thanks, Andrew. My experience is when I practice in the UK, probably the proportion of smokers to diabetic peripheral arterial disease is in a region of about 70% smokers versus 30% diabetics. Whereas now I'm finding that my practice is mostly dealing with 90% diabetic CLTI. The proportion of claudicants versus CLTI is also different. I'm dealing with more or less 98% CLTI, maybe 2% claudicants in Singapore. In terms of the interventions, these are also different. We were already practicing majority endovascular revascularization in the UK already. However, the proportion of endo to open was about 80-20 in the UK. In Singapore, the proportion is more or less about 98% endo versus 2% revascularization by the open technique. In fact, I probably remember doing one distal bypass in the whole of last year for my PAD patients. And these are largely the differences, really, between UK and Singapore.
Thank you, Eddie. June, I'm quite confident your own practice probably reflects all of ours in that a move from the UK to Singapore has really sort of pushed forward on endovascular. We don't really do open surgical approaches unless endovascular fails. But could I ask you, if that is the consensus here in Singapore, why is it that the Asian population is so different? Why do you think it is so difficult to treat? And do you think that there's a very dramatic paradigm shift that we've seen in Asia that is going to be replicated elsewhere in the world?
Well, first of all, Andrew, thank you very much for inviting me to this podcast, and it's a delight actually to speak with other of my colleagues as well. So just to answer your first bit of the question, I think I echo exactly what Dr. Choong has said. very much the experience is very different having trained in the UK and Australia. I think that one of the things is the anatomy of the vessels. The vessels are much smaller. If you look at our aortas, for example, let's just go with the big vessels. We know actually from the data that the aortas in Chinese people and in Asian people in general are about 10% smaller. And I tend to now go down the line of, we're not just a PAD kind of a podcast, but I tend to go down the line of treating aneurysms at 5 centimeters rather than the 5.5 centimeters for our Caucasian counterparts. So, and that reflects exactly what happens in the peripheral vasculature. The SFA, the tibial vessels are at least 1 or 2 millimeters smaller than our Caucasian counterparts, which makes bypassing and open techniques much more difficult. Also, the fact that these patients are diabetic, the multi-level disease that we have in these vessels are about 40 to 50%. So whether you're going to plant a bypass like a fem-pop bypass or a fem-distal bypass, you're doing almost endarterectomies at both levels. So that's going to increase the length of time of an operation and probably affect the outcome. Second thing of all is that actually getting some good conduit is very difficult. 90% of our CLTI patients, as Eddie said, is actually diabetic. And these diabetics don't have good venous conduits. The infection rates in tropical countries such as this is much higher. And plumbing on an artificial bypass, I think, does very badly. Yes, it may be used as a last resort to increase your blood flow to the foot in basically in last ditch attempts after multiple revascularization techniques. But when it takes an artificial bypass, it's another matter. But the infection rates are much higher and blowouts are much higher. And I found that when I first started. I must say, when I first started about 8 years ago, I tended to do about 10 bypasses a year. That's almost gone to zero because we can almost cross any lesion now, more than 98% of times using the more complex techniques. So I think it's varied. I think the anatomy is really great. And the last thing of all is our Asian patients are much sicker. If you look at the comorbidities, looking at the data, they are much more sicker than our Caucasian counterparts. And if you look at how bad their hearts are and doing a major bypass, I think the mortality rates are going to sky high. So that's one of the reasons why we use more of a minimal footprint, such as using these endovascular techniques to get ourselves out of trouble. But I think patients want that too, as well.
Thank you, Tjung. That's a really nice summary of some of the problems that we're all facing here in Singapore. And so this segues quite nicely onto the next thing I really want to discuss. So we've all agreed that an endovascular-first strategy, for all the reasons that everyone's mentioned, is clearly the way that Singaporean vascular surgeons and our colleagues have decided to treat our patients, and we think it's for the best. But we will all realize and recognize Katsanos's very interesting meta-analysis on the Paclitaxel controversy. And I just wanted to know what people's thoughts were in the setting of an endovascular-first approach to lower limb revascularization. What does the Paclitaxel data really mean to all of us now? And how has it impacted on your practices and your choices and how you approach a lower limb revascularization? Eddie, could I start with you?
Thanks, Andrew. When you talk about paclitaxel coated balloons, we need to talk about two things. Firstly, efficacy. And when you talk about efficacy, we need to divide the efficacy in two regions. Firstly, the SFA and popliteal, and secondly, the BTK. The second thing to talk about paclitaxel is the safety issue of paclitaxel. So I'll talk through both of these issues separately. In terms of its efficacy, we all know that paclitaxel is effective in SFA and popliteal. The randomized control trial data for that is plenty, and there is basically no debate really. However, for BTK, paclitaxel is more debatable in terms of its efficacy. We all know from the Medtronic Impact Deep RCT, which showed that in the Paclitaxel group, the rates of amputation was nearly threefold compared to the control group where they use standard balloon angioplasty. And that's the reason why the Medtronic's Impact Ampheron DCB was withdrawn from the market. And since then, there have been no real big RCTs, really. The last RCT, the last big RCT was the Lutonix RCT for below-the-knee disease. And that, in terms of its endpoint, showed a slight favorable outcome for DCBs for below-the-knee arteries in terms of occlusion versus no occlusion. In terms of its safety, the Katsanos meta-analysis tells us that at 2 years, there is about a 68% increase in mortality, and at 5 years, there is a 93% increase in mortality. And the higher the dose of paclitaxel, the higher the chances of death. So it tells us something. Now, paclitaxel in itself, this is an anti-cancer drug. Paclitaxel is designed to kill cells. I'm not sure if many people realize this, but Paclitaxel was originally derived from the yew tree. And the yew tree is also nicknamed as the tree of death. Every part of the tree is poisonous, except for the red arrow. And even then, the seed within the red arrow is also poisonous. And in the olden times, people used to commit suicide by eating pieces of the yew tree. In fact, if you look up the internet, there have been instances where cattle and livestock have all died because somebody has thrown yew tree seeds over the fence. So paclitaxel in itself is very effective. It is designed to kill the cells, and it is designed to kill the smooth muscle cells in the wall of the arteries, and that's why it's so effective at preventing neointimal hyperplasia. But we've all got to heed the results from the Katsanos meta-analysis, which showed an increased mortality. So in terms of paclitaxel, this is where we're at. We know it is effective for SFA. It is not so effective for BTK, and there are certain safety signals as evidence from the Katsanos meta-analysis.
That's great, Eddie, and thank you for setting up the next 2 points so nicely for me. I'll get back to everything that you've said in just a bit. But with all this talk about below-the-knee disease, paclitaxel balloons, what we do, endo, open, Tjung, could I invite you to talk about your MERLION trial, please, and to explain the rationale for why you thought it was appropriate to do, what you thought that you would achieve by doing it, and could you just share your results with us, please, and what the future is from the point of view of a PI?
Sure. So just to put a point to it, there is no real good evidence for use of paclitaxel-coated balloons in the below-knee pop area, tibial vessels. There is really a lot of conflicting data. The randomized trials don't really highlight any benefit if you put the data together. Recently, the Singapore trial, the RCT from Singapore General Hospital from the interventional radiologist suggested a worse amputation-free survival using paclitaxel balloons over plain angioplasty, which was highlighted again with the Impact Deep trial that Dr. Choong has just spoken about. So there is no real good evidence, to be frankly honest, for BTK paclitaxel drug-coated balloons. So, in fact, the MERLION trial was really there to really test. All RCTs choose the best possible lesions. What I really wanted to do with MERLION was to actually show in what is a very, very much an everyday practice in Singapore, how bad our lesions are in the BTK area. So I just put a registry of 50 patients, and I decided to take it from 2 centers, one from Singapore General Hospital and one from Paclitaxel Hospital with Dr. Leong Cho Ren as the PI there, site PI there. And we combined our data over about a 9 to 10-month period. And basically, we wanted to take the worst lesions, the TAR C and D lesions, in the setting of CLTI. So these were not claudicants. So what we did was we concentrated on the BTK lesions. And I must say, some of these patients, over, I think it was 94% of these patients were diabetic. 50% had end-stage renal failure. Now, if you put it into perspective, these demographics, these are the worst kind of statistics if you compare it to any of the randomized controlled trials, where diabetes makes up maximum 30-40% of the population. ESRF is only making about 20-30% at best. So these are really bad, really start off. And if you look at Rutherford 5, Rutherford 6 lesions, they made up about 94% of the population. So rest pain was about 6%. And if you look at the mean target lesion lengths, they were nearly 20 centimeters. So you're looking almost, CTOs were almost made up half of these lesions. So these are the worst lesions you're going to get in this real life setting. And what we found was that if you prepared the lesion well with a POBAR and then for a plain angioplasty and then coated the whole of the lesion, so I'm talking about from do not have any geographical miss, our 6 and 12 month data is not bad in the context of what you have. So technical success rate was very high, as you expect with any endo technique. 100%, I think the technical success rate was. The 6 and 12 month amputation-free survivals, over 80% at 6 months. It drops down to about 70% at 1 year. Target lesion primary patency at 6 months was in the high 80% and then dropped down to mid 70% at 1 year. Mortality rate wasn't bad. It's about the usual what you expect for this type of population of patients. 1 year mortality rate about 12-13%. So in what we can do, and then improvement in Rutherford score. So there was at least 60% improvement in Rutherford by one Rutherford score at 1 year from baseline, and wound healing, total complete wound healing at 1 year in this setting was around 65%, which is not bad when you compare what these lesions were, or what these wounds were when they presented. And with very bad Wi-Fi scores at the beginning, and a bad baseline toe pressures of about 40, those kind of results are real world data, and you don't see those in the randomized trials. And what I found with these Paclitaxel is that the reintervention rates were much lower than what we had from a historical cohort using conventional balloon angioplasties. But what I really think actually is may not well be drug. I think it's the way you prepare the lesion and actually angioplasty those long CTOs, and how you can keep up the balloon. Some of the newer techniques of keeping the balloon up longer, using long balloons, using high pressure, non-compliant balloons, using specialist balloons if you have problems like cutting balloons to make sure you efface the lesion properly. I think those are things that are very important, and the drug really only adds to it to prevent the neo-intimal hyperplasia that occurs towards about 30 days onwards. So actually, to do all the lead problems with restenosis, your drug only really deals with neo-intimal hyperplasia and not recoil. So I'm pretty happy with it, but the question is, we could do better.
Tjung, thank you for that summary. There's a few things that immediately spring to mind when I saw the data, and I've heard you now talk. Two things really. With such a preponderance of diabetics and end-stage renal failure, we know that the below-the-knee disease is probably mostly calcified disease. And so it really goes to the last points that you were making. When you're preparing these lesions, these drug-coated balloons require a longer prolonged inflation time as per their IFU to deliver the drug. So I know you'll never be able to unpick this, but how much of the drug really has an effect on this, as opposed to just treating these long segment lesions with newer long balloons, as you said, prolonged inflation time, non-compliant balloons? You kind of mentioned all of those things. How much do you think neo-intimal hyperplasia really plays a part in the below-the-knee vasculature?
That's a very good question. I don't think anyone can answer that question truthfully, to be frankly honest. Yes, calcium, they say, is a barrier for drug absorption. How much truth to that is, I don't really know. If you look at some of the data that's coming out now, look at Barlux P3 using the Passio 18 lux Paclitaxel balloon, you look at the calcification rates in the BTK area, they were very high. Moderate to severe calcification was nearly 2/3, but they're still getting very good results of low target lesion revascularization rates. Even our local data using the Passio 18 lux balloon, our reinterventions are very low, despite 70% having severe calcification of their BTK vessels. So I am not sure how much that really holds true. What I think neointimal hyperplasia really kicks in at about 1 month, followed after 1 month. So if your reintervention rates are before 1 month, I think there's a recoil element, or having not effaced the lesion properly, or just very bad recoil disease. So I don't think neointimal hyperplasia plays all that much of a role. If you look at some of the data with just POBAR below the knee, and we've achieved rates using high pressure non-compliant balloon rates of over 70% at 1 year. And then if drug only adds about 10%, which in some of the data it does show in a lot of studies to about 80%, there must be more than just recoil, or just more than neointimal hyperplasia at work here to actually only get that extra benefit from drug.
Thanks, Tjung. And just very quickly, you've got a long segment below the knee CTO, you've got it open, you've POBAR'd it, you've drugged it, you've done whatever you need to do. It looks beautiful in angio, wound is healing. What is your post-operative antiplatelet and anticoagulation regimen of choice, and why?
So when you've given a drug coating to any peripheral vasculature vessel, whatever, normally what I do is I do a dual antiplatelet therapy, i.e. with aspirin and with Plavix or clopidogrel for 3 months. The data there is probably level 2C evidence. It's not great evidence for that, but I prefer that because there's just a slightly higher risk of early thrombosis rates of those vessels. So we use that kind of regimen. But I've actually gone away from that, become more selective, whereby I even actually put patients on an antiplatelet agent and a low-dose antithrombotic like Xarelto, 2.5 milligrams BD. We have that here at SGH on the pharmacy. And I look at them, and especially I do that in multi-level segments, especially if I think there's going to be an early chance of recall or early thrombosis rates. And I think for ESRF, I think there's subpopulations of patients, those with bad hearts, with congestive heart disease or cardiomyopathy, and those with ESRF, I would actually put them on that kind of regime. So I think you need a bit more than aspirin, but what exactly, there's not enough evidence to suggest which one.
Thank you. And I just want to stick with below the knee disease. Thank you both for your insights on it. And thank you, Tjung, particularly for your really encouraging trial data. But a lot of that is surrounding sort of still Paclitaxel. And I wanted to frame this conversation earlier on, specifically talking about the Paclitaxel controversy and what it all means, knowing full well that then we would go on to talking about below the knee disease and further Paclitaxel devices. Eddie, sirolimus, could you tell us a little bit more about that, a little bit more about the work you're doing in that space, and where you see sirolimus as a future technology, and particularly as it may apply to the below the knee vasculature?
Thank you, Andrew. I see sirolimus as a potentially exciting alternative to paclitaxel for both SFA and popliteal disease, and also for BTK disease. Having heard, Dr. Tang's data for the MERLION trial, I have to say that it is also exciting that we are getting this more updated data on paclitaxel's use in BTK. And similar to Dr. Tang's MERLION trial, which looks at Luminor's paclitaxel drug-coated balloon in BTK, there's also evidence from China looking at their ORCID DCBs, and they've also recently published very good data for the use of paclitaxel in BTK disease. And Medtronic, although their initial impact deep showed a negative result, they have gone to devise another BTK Paclitaxel drug-coated balloon, the Impact 014. And they've also recently reported very good outcomes for that for BTK disease. So the first thing to say is that Paclitaxel may be coming back for BTK disease, and it is an exciting area to watch. Now, for me, sirolimus has got certain advantages over Paclitaxel. The cardiologists have known this for many, many years, and they've moved on from using Paclitaxel eluting stents to using sirolimus eluting stents for the last 15 years. And the reason for that is because, first of all, when they looked at their meta-analysis of sirolimus eluting stents versus Paclitaxel eluting stents, they can see a very clear difference in superiority for their sirolimus eluting stents in preventing restenosis, in terms of angiographic appearance, and also in terms of freedom from target lesion revascularization. And when they actually looked at the differences between sirolimus and Paclitaxel, sirolimus has certain superiority. Both will inhibit smooth muscle cell proliferation and endothelial cell proliferation. But in addition, sirolimus also inhibits smooth muscle cell migration to a much greater degree than Paclitaxel. As I mentioned earlier on, Paclitaxel was originally designed as an anti-cancer drug. It kills things, whereas sirolimus is an immunosuppressive drug, and that means it can prevent inflammation. And this is also evident when they looked at the coronary arteries histology. They found much less inflammation in their sirolimus eluting stents. The third thing is with regards to the differences in terms of the cytotoxic versus cytostatic. So sirolimus is cytostatic, which means it just prevents the cell cycle it arrests the cell cycle. Whereas Paclitaxel is cytotoxic. It prevents the cell from dividing, and at that point, it kills off the cells. So from that point of view, intuitively, you would think that sirolimus is safer than Paclitaxel. Then the other thing is that when you look at the use of sirolimus in BTK arteries, and I think this is in terms of the difference in terms of the delivery. Sirolimus is a little bit different to Paclitaxel. The disadvantage with sirolimus is that it is very difficult to get it into the vessels. And when you get it into the vessels, it is very difficult to let it stay there. Paclitaxel is advantageous in that it is easier to get into the vessels, and when it gets to the vessels, it stays there much longer. And Medtronic has got data to prove that Paclitaxel stays in there for as long as 6 months, and you could never get that with sirolimus. And that has pushed the various industries to go on to develop much better ways of delivering drugs into the artery. And the two main companies that deals with sirolimus-coated balloons, they're very innovative in how they choose to deliver the sirolimus into the artery. And just from the experience alone, I can see that there's much less flaking and there's much less distal embolization. So when you're dealing with very small BTK arteries, that's an obvious advantage. So I see that as a real advantage in terms of using sirolimus.
Thank you. Can you just tell me a little bit more about sirolimus as a compound itself and what its history is and what its safety profile is now? Because we're all very heightened and very concerned, and it would be very interesting to hear where its history is. And what we don't want as a vascular surgical community is to get excited about another compound, another drug, only to find 5 years down the line there is another meta-analysis that this time shows that there's a mortality signal with sirolimus. You know, it's obviously something that we're desperately trying to avoid because we do need these technologies. So maybe a little bit more about the compound, its history, and where you think the future is going with sirolimus balloons.
Sirolimus was discovered from a microorganism. Its other name is also rapamycin. And its use is mainly in renal transplant. And we give sirolimus, tacrolimus to our patients, mainly to prevent inflammation and it is also used as primarily an immunosuppression. It acts on the cell cycle on the G1 phase. So, and this G1 phase is when it stops the cell, it arrests the cell cycle at that point. So basically, it just puts the cell to sleep. So it doesn't kill off the cell, as opposed to Paclitaxel, which kills off the cell entirely. So Paclitaxel is extremely effective from that point of view. So when you apply it into the intima and media, it will kill off the smooth muscle cells and endothelial cells, and this is exactly what you want it to do. However, there's a potential for much more collateral damage because we know that a lot of the Paclitaxel gets washed downstream, and we find them in other parts of the body, such as the myocardium, the lungs, and everywhere else. So from that point of view, it's potentially dangerous. Now, sirolimus as well, there will be some collateral damage. It will be also washed downstream to other parts of the body, but because it is primarily an immunosuppressant, it doesn't cause, in my mind, as much damage to the body when you apply it.
Thank you. So, Eddie, can I just ask you, therefore, in your practice now, are you routinely applying drug-coated balloons below the knee? If you are, what's your first choice? And after that, same question to you about your sort of post-op medication regimen for your patients who've got these sort of long segment CTOs.
The answer to your question is yes. I do routinely apply sirolimus coated balloons to both SFA and popliteal disease, and also to below the knee disease. However, not all cases. There are certain cases where sirolimus coated balloons, or Paclitaxel coated balloons for that matter, I find do not work as well in BTK disease. And these two scenarios are, number one, when there is a lot of calcification. I believe that it is harder for the drug to be transferred across very highly calcified arteries into the media and also to the adventitia. And secondly, for lesions which require safari, so when you require retrograde access, most of the time it is subintimal. And I find that in those areas, drug-coated balloons don't work as well. So in those two scenarios, I may not apply drug-coated balloons. The second question, what was the second question again, Andrew? Sorry.
Just about what's your sort of antiplatelet and anticoagulation regimen after these patients?
Antiplatelet regime is dual antiplatelets with aspirin and clopidogrel for at least 6 months.
Okay, thank you very much. And do you find rivaroxaban has any role to play in your sort of current algorithm post-CTO angioplasty?
I find that I've not got much experience with using rivaroxaban. Primarily, and I was discussing this with Dr. Tang earlier on this afternoon actually, because our pharmacies, we haven't stocked up the low-dose rivaroxaban 2.5 milligrams yet.
That's a very fair point, and actually quite a difficult and can sometimes be unsurmountable challenge for some units. Thank you very much, everyone. We're coming close to the hour, so I'm just going to slowly wrap things up. Eddie, thank you very much for everything that you've spoken on thus far. Maybe just 1 or 2 minutes on where you see the future, what we're going to be doing in 5 years' time, and where you see our practice moving and changing towards.
I think in 5 years' time, we're going to see a lot of new exciting technologies. And that's why I find our area or specialty to be highly exciting. For BTK, I think we're very close to achieving an effective biological therapy, be it sirolimus or Paclitaxel. I think there will be more data coming out in the next 3 to 5 years. And these are level 1 data, randomized control trials. And secondly, we're also looking at stents for the use for BTK. There are multiple ongoing RCTs looking at the use of drug-eluting stents, and one of these is the live BTK, which is, I think, being run by Ramon Bacco from Sydney. So I think we're probably looking at more data on the use of stents for BTK. And we're also looking at how to deal with calcification for BTK. And this means the use of lithotripsy balloons, and also the use of atherectomy devices as a vessel prep for BTK in combination with various drug coating technology for the use of BTK. So CLTI treatment will continue to improve, and in 5 years' time, I think our practice for BTK arteries will be very different from what it is today. It'll be much more extensive.
And June, same question to you, just to finish everything off. 5 years' time, what are we going to be doing?
We're not going to do any bypasses. That's how I see it. I'll be honest with you. It's not because we can't do it. It's because there won't be the skill to do it. I'm going to be very honest with you. I think it's a customer-driven society. Patients do not want open cuts in their legs. The disease process, I think, is a big barrier to making a big long bypass successful. If you look at the demographics, BTK disease below the ankle disease is very significant in about 20% of our CLTI patients. And as you know, we need both a good inflow and a good outflow. I think, and the vein quality is so poor because 90% of these are diabetics. I think an ESRF is an independent prognostic indicator of outcome. We've looked at the worst R6 patients, the R Rutherford 6. The mortality rate at 1 year is nearly 30%. Who would want to bypass at that kind of rate? I'll be honest with you. I don't think it's just a question. I mean, I think it's very good for redo surgery, but I think for last-ditch surgery, but not. I don't think that many of these patients would want it. As I said, I think I agree with Eddie. I think there's a lot more technology coming. There's a lot more to work on in the BTK area. I think our wound salvage rates for diabetic foot is excellent in this country, better than in some of the first, in the US and in the UK, because we actually look after our own wounds. And our diabetes is more malignant compared to some of the diabetes that we see in the Western population. So I think we're doing well in wound care. I think wound healing, wound care, I think there's exciting areas as well.
Thank you, June. And it just leaves me with the task of saying thank you to you all. Thank you, Eddie. Thank you, June. It has been at least for me, fascinating look at the treatment of CLTI in Singapore and hopefully it can be applied to a wider Asian perspective. If any of the viewers have any particular questions on anything that we've discussed, I hope you don't mind if we maybe forward some emails to you all. And I very much look forward to having you all on again on either a similar or a separate topic in the near future. So thank you very much and enjoy your sleep. It's almost 11:30 here. So good night, everybody. Thank you.